this video. We have a beautiful day here in Northern California, and you can see the Sierra Nevadas behind me. I'm not sure if you can see from this camera angle, but there are some slightly snow-capped Sierras there in the background. And of course, we're hoping for more snow. This is being filmed in January 2014, and as you can see, it's not all that cold here. So it's a beautiful day to talk about the chiropractic or QME spinal exam. And today I'd like to talk about some topics of special interest with regards to the lumbar spine. And this material that I'm going to share with you today applies to all different types of examinees, whether that be in the medical legal setting such as a QME examination, or even in your clinical practice, whether you're a chiropractor, osteopathic doctor, medical doctor. This material applies to all of those situations. And within the entire subject of the lumbar spine exam, I want to narrow our focus down even more to the radiculopathy exam. And specifically, I want to focus today on the sciatic nerve root tension signs. Now, if you're a qualified medical evaluator or you're treating injured workers, our Bible, of course, is the AMA guides. And the AMA guides talk about sciatic nerve root tension signs, but they only mention the straight leg raising test as the only test that we use. And there are actually many different types of tests that we use to assess for sciatic nerve root tension. And I'm going to share 5 or 6 different tests with you here today. Now, the reason that we have 5 or 6 different tests is to use these additional examination tests or maneuvers to corroborate the findings of the other tests. So, for example, if you have a positive finding on the straight leg raise test, meaning you have a positive finding for radiculopathy, meaning that the straight leg raise test reproduces the examinee's symptoms of radiculopathy, that positive finding should be reproducible throughout these other similar examination maneuvers, all of which have as their purpose to traction or to stretch the sciatic nerve roots, which, as we know, include the nerve roots L4, L5, S1, and S2, and at least for the tibial nerve, S3. Now, most typically, it's going to be the nerve roots L4, L5, and S1 that we're going to be assessing, because those are the ones most commonly involved with typical radiculopathies that we see in our practices. So before we bring on a live subject to help us demonstrate these maneuvers, I just want to go over some philosophy about these maneuvers and some of the key observations that you're going to be attuned to spot during these examination maneuvers. And the first thing I want to share with you is that the sciatic nerve root tension exam begins with some observations during your examinee warm-up. And let me clarify that a little bit. The AMA guides require that before we put our examinee through range of motion maneuvers, we warm them up, so that when we get to our actual range of motion measurements, the examinee is all warmed up and is ready to give us accurate measurements. Well, as you take the examinee through their warm-up maneuvers to loosen up the lumbar spine, you're going to be looking for your first indication of sciatic nerve tension. And that comes in the form of a reflexive involuntary withdrawal reflex during the movement of lumbar flexion. Okay? So, you're taking your examinee through the warm-up procedure, and as they go through the warm-ups of lumbar flexion and lumbar extension, in the presence of a bona fide radiculopathy, let's say of the left leg, bona fide L5 radiculopathy, as the examinee goes through lumbar flexion, there's going to be a reflexive, involuntary withdrawal from a painful stimulus. What's the painful stimulus? The painful stimulus is a hot sciatic nerve or a hot lumbar spine nerve root. So as they go through lumbar flexion, there's going to be a reflexive withdrawal by flexing the knee, thereby slackening the nerve root at its painful point of origin. Now this is known as Neary's bowstring sign. And isn't the lumbar flexion maneuver the same as a straight leg raising maneuver performed with the examinee supine? It's actually the same maneuver. In my opinion, it's a more aggressive maneuver because the lumbar flexion maneuver occurs with the spine loaded in the weight-bearing position. With a straight leg raising maneuver, of course, the examinee is supine and the spine is not even loaded. So this is a more aggressive maneuver because the spine is loaded with the weight of the torso. And so, in the presence of bona fide radiculopathy, you're going to see a withdrawal reflex in the form of what's known as Neary's bowstring sign. And this Neary's bowstring sign is going to be a recurring theme that we're going to use to check for the presence of true objective findings on these examination maneuvers. So we'll go over how that would look in the context of each of these examination maneuvers when we bring on our live subject. For now, let's talk about a little bit about the philosophy of each of these examination maneuvers.
We go through one stop to the rhythm that divides you, and I speak to you like the chorus to the verse. Drop another line like a coda with the curse. Coming like a freak show takes the stage. We give them the games they play. So say I want something else to get me through this semi-tongue kind of life. Baby, baby, I want something else. I'm not listening when you say goodbye. The sky was gold, it was rose. I was taking sips of it to my nose, and I wish I could get back there, someplace back there, smiling in the pictures you would take. To a crystal method, lift you up until you break. It won't stop. I won't come down and keep stop with the tick-tock rhythm. A bump for the drop and then a bump.
Okay, so let's go over these maneuvers now. I want to share with you in this video 5 different sciatic nerve tension maneuvers that we do. And we already talked about Neary's bowstring sign. So we'll go over some of these other examination maneuvers as well. And you notice I have my AMA guides here with me today. And I just want to read briefly from page 375 out of chapter 15, the spine chapter. That's where the sciatic nerve tension signs are discussed. And the guides admit here that they themselves don't give us very much direction or instruction as to how to do these sciatic nerve tension signs. And so that's the purpose of this video, is to go over actually how these maneuvers are performed properly and to try and standardize the performance of these maneuvers among doctors so that we're all performing the same type of examination maneuver and all coming up with examination findings that would be reliable between examiners. That's also known as inter-examiner reliability. So that's my hope, is that we can standardize these maneuvers among doctors. So the AMA guides state themselves that, and this is a quote, says, "It is not the purpose of this text to discuss in detail how the physical examination is performed. Textbooks are available to cover that subject." And with regards to the subject of the sciatic nerve tension signs, the AMA guides themselves only talk about the straight leg raising maneuver. And they talk about the straight leg raising maneuver being done both supine and sitting. So let's talk about the straight leg raising maneuver and also the other sciatic nerve tension signs. So first of all, the straight leg raising maneuver is typically done with the examinee supine. Now, supine findings should be corroborated with findings of the same maneuver performed with the examinee standing, as I just demonstrated with the lumbar flexion maneuver, and also with the examinee sitting, as can be done with the sitting straight leg raise maneuver. Sitting straight leg raise maneuver. Okay, so typically, however, this maneuver begins with the examinee supine. So you have your examinee supine in the non-weight bearing position, and then you're simply going to take the relaxed leg with the ankle, the knee, and the hip of the examinee relaxed, and you're going to raise that leg en bloc, meaning you're going to raise the entire leg as one pillar, flexing only at the hip socket. Now, as you elevate the leg, flexing only at the hip socket, the first 20 to 35 degrees, and I say 20 to 35 degrees because references vary. The AMA guides themselves use 20 degrees. Other textbooks use 35 degrees, but whatever, you get the point. The first 20 to 35 degrees of elevation, which is about this angle, correct? This would be 45 degrees, okay? The first 20 to 35 degrees of angulation is simply removing slack from the lumbar spine nerve roots. There's no actual tension produced on the nerve roots yet. There's no actual stretching of the nerve roots across the disc yet. But slack is being taken out of the lumbar spine nerve roots. Now, the AMA guides say that the maximum tension is developed in the nerve roots between 20 degrees and 70 degrees of hip flexion. This is 70 degrees of hip flexion. Other references say it's a much narrower range. It's actually between 35 and 70 degrees, a 35 degree range. The AMA guides provide a range of 20 to 70, that's 50 degrees, where the maximum tension is developed in the lumbar spine nerve roots. So, based on that anatomic fact, there should be no report of lower back pain or radiating leg pain, radicular leg pain, in the first 20 to 35 degrees of elevation of the leg. A report of lower back pain or radicular leg pain in the first 35 degrees of elevation would be considered a non-physiologic exam finding because there's simply not enough tension developed yet. There's no traction of those lumbar spine nerve roots across the disc until we get to about 20 degrees, the AMA guides say. Other references say 35 degrees. Okay, so let's say we pass 35 degrees of hip joint flexion and the examinee reports lower back and radiating leg pain. Okay, so we have a positive subjective report of radiculopathy. Okay, now what would a true objective finding for radiculopathy in this scenario look like? What would constitute a true objective finding for radiculopathy in this scenario? Let's say your examinee was mute and could not speak to you, or you had a piece of duct tape across their mouth so that you could not make out what they were saying. What would a true objective finding to accompany bona fide radiculopathy look like? Well, we already alluded to it earlier. It would look something like the Neary's bowstring sign. In other words, as that leg starts to come up beyond 20 to 35 degrees, and as that tension develops in those lumbar spine nerve roots, tractioning those nerve roots across a hot disc, there's going to be some sort of reflexive, involuntary withdrawal reflex. It's a withdrawal reflex. It's a reflex. And that's the beauty of these reflexive findings. They're truly objective. The subjectivity of the examinee is overridden by the objectivity of a reflex. It's simply a withdrawal reflex. In other words, there's no examinee in the world who's going to allow you to continue to traction their lumbar spine nerve roots across a hot disc. It's a lot like touching your finger to a hot stove. There's a reflexive withdrawal from a painful stimulus. And in this case, the painful stimulus is a hot lumbar spine nerve root, which is going to cause the examinee to withdraw in one of several ways. The most common would be to withdraw by flexing the knee, thereby slackening the nerve roots at the lumbar spine. That's one form of a withdrawal. What would be another form of withdrawal? How about dropping the leg or forcing the leg down into those lower ranges of elevation to relieve the slack on the lumbar spine nerve roots? Now, this is a concept that is repeatable throughout all your physical examination maneuvers, not just the lumbar spine. And probably where this is most taught is in the upper extremity with regards to shoulder instability. When we talk about shoulder instability, we have a classic physical examination maneuver that we use. We call it the apprehension sign. You've probably seen it demonstrated as where the examinee senses some impending dislocation of the shoulder, and they give you this so-called apprehension sign. Well, what is the apprehension sign? The apprehension sign is a reflexive withdrawal to remove the shoulder from a position of impending dislocation. It's an involuntary reflex. It's a form of the withdrawal reflex. Well, similarly in the lumbar spine, we're going to see a withdrawal from a painful stimulus. It's a different painful stimulus, but it's a painful stimulus nonetheless, and that would constitute a true objective finding. So with the straight leg raising test, greatest tension is developed between 20 and 70 degrees. This is where you're going to see your subjective reports of pain in a bona fide case. This is where the pain is going to be reported. And then any subjective report of pain should be accompanied by some sort of a true objective finding. Simply a report of pain in the absence of an objective finding, oh, that hurts, is not a true positive finding for the straight leg raising maneuver.
Myself back to the place where you said I want something else to get me through this.
So that's the straight leg raising.
Some kind of lie.
Now let's talk about the next maneuver, which is Braggart sign. Braggart sign, also known as the sciatic nerve stretch test, is simply a modified straight leg raising test, and it can be sometimes used as a validity maneuver. It can be used as a standalone maneuver. It can also be used as a validity maneuver. So to perform Braggart's test, you simply take the straight leg raise test, and this is to be performed in a case of a subjective complaint of reproduced symptoms, reproduced radiculopathy symptoms. You simply take that leg and lower it below the point at which the pain is produced or at which the pain is reported. You lower the leg to alleviate the stretch at the nerve roots, and then you dorsiflex at the ankle to then recreate the stretch along the sciatic nerve back up at the nerve roots. Do you get that? First, we slacken the nerve roots here by dropping the level of the leg. And then we reestablish the tension here by dorsiflexing the ankle. In the case of bona fide radiculopathy, this should reproduce again the complaint of lower back pain and associated leg pain. Now, again, this should carry with it a true objective finding in the form of a withdrawal reflex. There should be some bowing at the knee, a Neary's bowstring sign, or some contraction to lower the elevation of the leg, thereby putting slack back in the lumbar spine nerve roots. What else would slacken the lumbar spine nerve roots? How about reflexive plantar flexion at the ankle to minimize the traction effect of the dorsiflexion? That would be a true objective finding. How about an examinee that let out an utterance such as ah, ah, while simultaneously plantar flexing at the ankle? That would be considered a true objective finding. Any one of those withdrawal responses would be a true objective finding to accompany a subjective report of pain. So that's Neary's bowstring sign. The next one that I want to share with you is known as the popliteal compression test. And these are all just takeoffs of the straight leg raising test, and they can all be done in sequence and used one to validate the other. And before I talk about the popliteal compression test, let's add in another validity maneuver for the Braggart's test. So let's say that we have a strong subjective report of pain with ankle dorsiflexion, right? A positive Braggart sign. What type of a response would we expect if we then take that ankle and plantar flex it? We would expect that that would alleviate the symptoms, correct? So in the case of strong plantar flexion of the ankle, if we get a subjective report of back pain or radicular leg pain, that would be considered a non-physiologic exam finding. Okay, now with the popliteal compression test, it's performed a lot like the Braggart's test, in that we take the straight leg raising maneuver up to the point of reported pain, lower it slightly, and then using our thumbs while supporting the leg on our shoulder, using our thumbs, we then traction the nerve, the sciatic nerve, in the popliteal fossa. Now recall that the sciatic nerve is actually two nerves. It's the conjoined common peroneal nerve and the tibial nerve, both wrapped up and invested in the same fascia, the same epineurium. The epineurium becomes continuous with the dura of the spine. So common peroneal nerve arises from the nerve roots L4, L5, S1, and S2. Tibial nerve arises from the same nerve roots L4, L5, S1, S2, and also a twig from S3. And they travel down invested in the same fascia. It's actually two separate nerves, but they're invested in the same epineurium, and we call this the sciatic nerve. Well, about 2 inches above the knee in the popliteal fossa, these two nerves separate. They separate out. And the common peroneal nerve goes lateral in the popliteal fossa. And you can remember that because sometimes the common peroneal nerve is referred to as the lateral popliteal nerve. So it goes laterally in the popliteal fossa, while the tibial nerve goes medially in the popliteal fossa. So you use one thumb laterally, one thumb medially, and you apply pressure to tether these two individual nerves in the popliteal fossa. And that further tractions the sciatic nerve up against a hot disc in the lumbar spine. And if those nerve roots are hot, this should reproduce complaints of back pain and radiating leg pain. It can be used as a validity maneuver, and it should be accompanied by true objective findings in the form of a withdrawal reflex. Now, It is possible to have a subjective report of pain and a bona fide condition in the absence of a strong withdrawal reflex. However, not many examinees are going to allow you to cause them significant pain with your examination maneuver. Significant pain will be accompanied by withdrawal reflex. If there is no withdrawal reflex, it gives you an indication as to the possible severity of the condition. In the absence of a true withdrawal reflex, conditions likely mild at most. Correct? Okay? So we should see true objective findings in the case of, a bona fide hot radiculopathy. And then finally, I want to go over with you the slump test. Now, I've found that not many doctors do the slump test, but this is a beautiful test to be performed, and it can be performed like the straight leg raising test, which can be performed supine and sitting. The slump test can also be performed supine and sitting. So if you do the straight leg raising test supine and then do it sitting, such as the sitting straight leg raise test, which many doctors do as a validity maneuver, you could also do the supine and sitting version of the slump test. Now, in the sitting posture like I am now, the slump test is simply a series of maneuvers designed to maximally tension and traction the dura and the lumbar spine nerve roots. So the slump test begins by first having the examinee, this is the seated examinee, having the examinee slump at the torso and the thoracic spine. And this increases the kyphosis of the thoracic spine, thereby increasing the tension on the dura through the thoracic spine. So we slump the thoracic spine, we slump the shoulders, and then the doctor gives added overpressure to the back of the neck and the upper thoracic spine, fully tractioning out every bit of flexion available in the cervical spine and the thoracic spine, thereby maximally tractioning the dura throughout the cervical and thoracic spine, and bringing all the dura in the lumbar spine and the lumbar spine nerve roots to tension. Then we simply perform a straight leg raising test by having the examinee extend at the knee and dorsiflexing at the ankle, just as we did when they were supine. So this is actually a straight leg raising test. Can you see that the angle between my leg and my torso is here approximately 80 to 90 degrees, with maximum tension being applied to the dura. Now the doctor simultaneously applies overpressure here at the cervical spine while assisting with extension at the knee and even assisting dorsiflexion at the ankle. Now in the case of a bona fide radiculopathy, this maneuver should reproduce symptoms, and this maneuver should be accompanied by true objective findings, such as a withdrawal, such as an extension at the head, such as an elevation at the thoracic spine, such as a flexion at the knee, such as a plantar flexion at the ankle. There should be some reflexive withdrawal from this painful stimulus. That makes sense? Okay? Now, in the supine position, we perform this same maneuver. We don't call it the slump test. We call it the Koenig/Brudzinski maneuver. Koenig/Brudzinski maneuver is how it's referred to in the orthopedic textbooks. And you simply begin with the examinee supine, and then you as the examiner would elevate their head, thereby flexing the cervical spine by bringing the chin to the chest, applying overpressure slightly, and then performing a straight leg raising maneuver with simultaneous dorsiflexion at the ankle. Same maneuver, different position. Should the findings be the same? findings should be the same, supine and sitting. Just like the straight leg raising maneuver should have the same findings, supine and sitting, and any contradiction between those two maneuvers could constitute a non-physiologic exam finding, could raise your suspicion for symptom magnification. Okay, so those are the 5 maneuvers that we're going to demonstrate now with our live model. It's going to be the straight leg raising maneuver and all of its variations, the Braggart's maneuver, the popliteal compression maneuver, and the slump test. Okay, so let's move now to the demonstration with our live model.
She lives for me, says she lives for me, ovation.